Okay, so we're live now. So hi everybody, welcome to the part 2 of the 3-part series Chris and I are doing to help general dentists learn a little bit more about dental sleep medicine, which is a pet topic. Now the last lecture we gave, we discussed a little bit about pediatric sleep diagnosis and screening. Today, we want to talk about something that all of you will face, and that is that patient who comes in as an adult and you know that they have extreme wear on their teeth based on what we call bruxism and what the patients call grinding. So we're going to try and dispel some myths and explain to you the differences in a sleep bruxism patient, which is very much related to apneic events versus possibly just the stress ed patient that we were all taught to deal with in dental school. And what we're trying to say is the stress patient, nothing really new other than the flat plane splint, but maybe varying the vertical dimension of the splint to make the splint more effective. That's something new you might pick up tonight. But when it comes to the sleep patient, you may not want to consider a flat plane splint, and we're going to show you why. Now, Chris, I'm going to get you to say a few words while I open up my other 3 Facebooks. So I'll hand over to you.
Thanks, Derek. Well, hello, everybody. And I'm hoping tonight we're going to give you some helpful tips on what kind of splints are suitable for what kind of patients. Throughout this lecture, there are some notes that allude to particular kinds of facial movement, bruxism style movement that's happening in a patient as detected by the sleep test that you can't see in a clinical observation. And that can actually give you a better indication of what kind of splint to use and actually when not to use certain kinds of splints. Now, I'm not trying to criticize any particular type of splint used tonight. In fact, if anything, I feel like the bit that I'm talking about, which has to do with anterior deprogrammers, is probably a helpful hint to actually finally put a full stop behind some of the problems that people seem to have with these things without actually understanding why. So how are you going, Derek? Keep talking.
Chris, I mean, the main question dentists want to know is just practically, they all know how to pick up the bruxism in the mouth. They just want to know, is there a way to deal with it? Because I can share this anecdote. I say to patients who sort of balk at getting a sleep study, I'm talking while I'm opening up all my Facebooks here, I say to them, look, if I just make you a splint and we don't diagnose what's causing your bruxism, then effectively what I'm doing is if I see you hitting your head against a brick wall and I come over and give you a pillow to cushion you hitting the brick wall, really done a lot for you, right? And in the same way, if we can identify what's causing the bruxism and try and reduce that, that's far better than just whacking some plastic between the teeth to prevent wear of the teeth. I guess that's one of the take-home messages. And Chris, I'm on my last. To be Harry fills around with his computer on a regular basis. And so every time I come back to present a lecture, I've got to figure out which Derek Mahony he's put in online. Now, we are currently live. Now I'm going to just make sure I share that one. Right, done. Much easier. So I've shared the number 4, number 3. I'm now sharing 1. Good. All right, so we should be live on all 4 Facebooks. Now, doctors, if you come on this lecture late in the presentation and you want to review it, I leave the lecture up on any of my 4 Facebooks. That's Derek Mahony 1, Derek Mahony 2, and Derek Mahony 3. And what that allows you to do is to watch the replay. Then after 3-4 days, we move it to a website called EODO Teachable.com, which allows you to answer multiple choice questions and get CPD for the actual lecture. It also allows you to share the lecture with friends. Now, I leave all my Facebooks public. That means that if you find this interesting, just please free to share it. We're here all about education. So, we don't care who does your sleep study. We don't care who makes your splint. We just want the patient to get the correct diagnosis and the correct appliance. That's what really it's all about. Chris and I are both busier than hell, but it's a passion of ours to teach dentists probably what they weren't taught in dental school, okay? I know when I went to dental school, we had 2 lectures on occlusion, and we had to make each other Michigan splints. Don't ask me why. And we had to wear them until we either got TMD or we cured our TMD, whichever sort of came first, So when I graduated as a young dentist, the moment I saw anyone who had a click, the moment I saw anyone who grind their teeth, the moment I had anyone I think had anything to do with TMD or what we call TMJ, I just gave them a splint, because that's what I was taught. So now it's a whole different ball game, and that's what I want to kind of share with you. Now, Chris,
and a word on that EODO TV. I had a look at that today. That's pretty cool. I mean, I scrolled and then scrolled some more on all the different content that's up there. The only reason that the lecture that we did last Thursday is not up there is because Mr. Kelly's been a bit slack on writing some questions. So I'll get onto that.
Now, I'm going to try and move my screen because I've gone to the second slide. Now, Chris, just confirming you're on the second slide, right?
Yep, that's working.
Yep, okay. So the question is, let's define Bruxism, right? And we've got 3 references there. By the way, if you want a copy of any of these slides and or the references, feel free to send me an email. It's info@mahony.com. And Chris and I are happy to get that information to you, right? So there's 2 main types which we're going to define: a primary or a idiopathic bruxism. There's a secondary type which is normally related to a medical condition, and depending on who you read, maybe 60% of the population has bruxism, right? And of course, self-reported bruxism is really low in quality statistics. What do I mean by that? If you ask an average patient, hey, do you grind your teeth? They're going to say no, right? Straight away. So why even bother asking that question? Right?
If there's no pain, they're not going to say yes.
Exactly, right? And in fact, accuracy of self-reported bruxism is less than 10%, right? I've got to be careful though, because a few weeks ago, Chris, I had a male patient in the chair, doing my consultation for ortho, and I said, look, you must grind. And he looked at me and he said, how did you know? I didn't see you at the nightclub. And I didn't understand what was going on until my assistant was nearly wetting herself laughing. And then later she disclosed to me, look, that was a gay patient. And the term grinding at night is a whole different thing to what you're thinking, right? So I learned something there. So I think when you ask a male patient, do you grind at night? I think you've got to add the word, do you grind your teeth at night? Right? Yeah. And another cause of bruxism, I have a lot of teenage patients, Chris, and let me tell you, particularly this in suburbs, they're all doing recreational drugs, okay? And all the recreational drugs they do cause them to grind their teeth. How do I know that? What happens when you get patients come in wanting wanting a mouth guard?
Yeah.
They don't play any sport. You can tell just by looking at them, right? And then they say, we want it to glow in the dark. And then I say, hang on, you want a mouth guard, you don't play any sport, you go. And then they disclose to me, probably when their parents aren't there, because we're going to a rave party and, we want to stop things. So there you go. Add that as another cause of adolescent bruxism, right? Anyway, so let's talk about secondary bruxism related to a medical condition. And what we want to talk about is the big one, which is sleep disordered breathing. But you also have movement disorders. A common one in people is restless leg syndrome. But, if you diagnose the correct condition, then you'd co-treat that. So restless leg syndrome, high iron deficiency, Your blood workup will show even normal is not enough, blah, blah, blah. We talk about rapid eye movement behavior disorder. When we talk about the apneic events, you'll see the microarousal is what triggers the masseter to get the tongue out of the way. So, you know, and then I want to bring this whole concept of Botox. Everyone's really big on putting Botox in anyone who bruxes, but if they're bruxing to open up their airway, Botoxing them may worsen their apnea. And this is where you've got to be careful from a medico legal point of view, right? So
a couple of other things there, though,
yep.
that I'm hoping we can get across to people as takeaways is the type of bruxism that's going to be detected if you've
yep.
done it properly. So, I mean, you know, generally speaking, the sort of sleep bruxism that you're seeing, which is semi-voluntary and subconscious, is going to be more phasic, so chattering and tapping.
Yep.
And the closer you get to a really long sort of clenchy, grindy thing, the closer you are to awake bruxism. So, I mean, we'll go on about that a bit more in the lecture, but depending on the stage of sleep, that's where we're going these days with bruxism. We're starting to really drill down to easily being able to tell somebody who has to deal with a patient what sort of bruxism they've got, which can open up a whole new conversation.
And I think what's interesting, you know, if a patient wakes, you know, in the middle of the night or in the morning and they start saying, oh, I've got these really sore jaw muscles, you know, they might go to the dentist. But if they wake up with no pain, but they feel really tired, the last person they want to go to is the dentist. Would you agree with that, Chris?
Absolutely. Like they don't sort of go, oh gosh, I'm having a terrible night's sleep, I think I'll go to my dentist. They don't do that.
So the thing is, you know, you've got different signs and symptoms of the similar problem, right? Now, here's the problem. You and I have just looked at 100,000 sleep studies, Chris, and you know, when the sleep community looks for bruxism, they detect it with audio and video as their gold standard, but that's not really the gold standard. And if you ponder that for a second, it takes not that long to understand that this gold standard is only going to pick up the worst of the worst, right? If you add EMG to something they're looking at, now you're going to pick up more bruxism. But again, because the medical community, associate the bruxism as a REM behavior disorder, then they pick it up with the restless leg type thing. So therefore, they're sticking, is the right term an electrode? No.
Well, yeah, I mean, but it's an electrode, but they're actually trying to pigeonhole the sleep bruxism they see into the international classification of sleep disorders, REM behavior, you know, disorder. So it's an RBD in their opinion. So that's why they're looking for the worst of the worst. There's good reasons they're doing it, and we're not trying to slam the sleep community, for God's sake. I've just joined it. But the point is, like they are looking for the worst of the worst. So if you're relying on a sleep test from a dedicated sleep modality, you probably are going to get a lot of negatives when you could actually be detecting things. You know?
And I think that's because they're using the EMG on the leg, right?
Yeah.
So if as a result, they're not going to pick up, I guess, any concomitant facial myoclonus. Whereas we as dentists, that's what we want to look at, right? So EMG on the cheeks is an important thing. And I think you're good at remembering names, but is it Tommaso Castofloro et al.? I love that name. It sounds like an Italian mafioso guy, right?
Yeah, it's like
Tommaso,
an Italian guy born in Brazil or something. You know, Tommaso Castofloro. Like, but I've actually spoken to Tommaso. Lovely guy, very serious man. But he's.
Was he behind that? He wasn't behind the Bruxsoft device, was he?
He was heavily involved in the Bruxsoft device, and a lot of big studies were done in Italy on that. Yeah. And they did a lot of good stuff, you know.
They were missing the related sleep sort of problems, isn't it? So it's one or the other.
Yeah, because they were actually walking, and it happens, you know. You get a bit tunnel vision. They were looking straight down the barrel of, we've got to detect bruxism, we've got to do it. But in the end, bruxism, as you know, Gilles Levine, you've had quite a few meetings with that fella. He
In fact, I'll give you a little plug here. I introduced you to him over lunch in Singapore once, and you know what? He left that meeting. He said, "Derek, that guy really knows his shit." That's what he said. So to have that from Gilles Levine, that's pretty big for you, Chris.
Yeah, well, Gillian, who works for me, she says I'm his biggest fanboy. So that's another plug in my cap, I guess.
But now this slide's interesting. 25% of people who have overnight bruxism also suffer from certain sort of breathing. So if you're just treating the grinding, you're missing 1 in 4 more serious problem. That's just one way to look at it. But I think I'll whack the next slide on here, right? So dentists see patients for bruxism and pain in their jaws, right? And we know that sleep bruxism, depending on who you read, is going to be 12.8% of the adult population. But you have this triad of restless leg syndrome, migraine, and bruxism. 29% have restless leg syndrome. So contrary to the restless leg syndrome patients, the sleep bruxism patients don't complain of sleep disturbance. So that sort of makes you sort of wonder, well, what can we do to try and hone in on what really is wrong with the patient? Chris, you want to add more onto that?
Well, that 12.8% of the population is actually the gold standard, absolute, concomitant audio and video sleep bruxism. That's the REM behavior disorder bruxism. I mean, the medical reasons they're trying to figure that out is because there has been a link between REM behavior disorder and that break of atonia with Parkinsonian type onset. So it's terribly important to know that that's the case. However, whilst it's totally possible to see that in other types of sleep tests that don't have audio and visual, you're going to pick up so much more when you're using facial electrodes instead of leg electrodes. But on the subject of that triad of symptoms, remember good old Dave Dickoff.
Yep.
His 10-year study. And I mean, what a fantastic study that was. They found that 51% had the full migraine, restless legs, and bruxism happening all at the same time.
Great.
I mean, wow. Look, they treated them with dopamine agonists, and as you would well know, dopamine agonists are going to work well on Parkinsonian symptoms as well. So I've also heard that clonidine, isn't it? Clonidine's the big savior for people with, but there's side effects. So, but that's the pharmaceutical sort of route. And that, again, is for those REM behavior disorders where people's sleep is primarily disrupted from the excessive movement of the whole body, and the bruxism's more of a side effect, wouldn't you say? Like, yeah, so look, ultimately, dentists are already looking at bruxism historically in the mouth. I mean, they're going to say, yes, you do grind your teeth. Yeah, there's evidence of it. And like you've alluded to, Derek. But
here's the other thing, Chris. Dentists don't seem to, I get dentists say this all the time. Yeah, but my patient's a mouth breather, so how can they brux their teeth? You hear that, don't you, right? And this is what I try and tell them. Am I right in saying this? Most grinding starts from an open mouth, freeway space posture, right? Yeah. But the next action after some kind of stimulus, whether it's a micro arousal, etc., is the teeth close together, right? So don't think that someone who tends to have their mouth open most of the night is not a bruxer. That's actually not true.
Yeah, exactly. I mean, we get told that during sleep, even let's stay with awake patients. Awake patients only put their teeth. How many times, you got those stats in your head? How many times do people actually get their teeth together during the day? It's not very often.
No. Well, Johnson Chu, my prosthodontist, he says teeth should only be together for about 10 to 15 minutes for the entire 24 hours. And that is just after you swallow, your teeth should just touch, right? Yeah. So those people who are putting their teeth together for, like, a lot more than 10 to 15 minutes. You see them when you pull up in Sydney traffic and you look next door and there's someone trying to do their best Clint Eastwood impersonation with the stress of the red light. You've seen them, haven't you?
Oh yeah.
Yeah.
Very good. Yeah.
Yeah. I had a patient who came in once, and I was asking him all the questions as to, why he was getting all this jaw pain. And I asked him, look, what sort of foods do you chew? And then we came to the end of the conversation, and he figured out his own problem. He, as a kid growing up, used to love chewing coconut. And then 20 years later, he comes across a shop that had coconut on sale. So what did he do? He went home and he ate 2 coconuts. It must have taken him all night, right? And then he started getting all this myalgic pain. So that was a pretty simple diagnosis, right?
Yeah,
but I think we're yeah, exactly, right? Yeah. Okay, now I'll forward to you take over on this slide.
Well, like we were talking about how actual dyed-in-the-wall sleep bruxism is only about 12 to 13% of the population. But that number's bound to be revised as methods of bruxism become more obtainable and beyond the lab type test and more into the type 2 studies, and then to a lesser extent we've got at least some confirmation of the fact that people have some kind of activity with limited channel bruxism studies that are done, or screenings like the Bruxoff. Like detecting different types of bruxism, awake bruxism and sleep bruxism, idiopathic pain-related bruxism and psychosocial bruxism. They're for the level 1 study if you want to go the whole gamut. But in the end, the characteristic of electromyography is found in repetitive and recurrent episodes of what we call RMMA, which is, now I'm going to stumble on this, rhythmic masticatory muscle activity. Oh, I did well.
And I've heard you try and say that when you've had a few drinks. Well, it's quite funny.
Rhythmic masticatory muscle activity. There, I almost got it right.
Right.
And that's the masseter muscle, clearly. And temporalis. Oh my God, the temporalis muscles.
How have you been drinking, Chris? Is my next question.
I don't drink enough during the day. I think that's what it is. The reality of those, they are associated with sleep arousals. But look, in the end, as dentists, we want to try and help to determine what kind of solution we can give a patient. Like bruxism is assumed to be stress related for many years, but it is stress related. However, since 2015, old mate Jill and others have been doing much research on the subject of bruxism activity, and those results mean that the sleep community, as I mentioned before, in the ISCD, they've made it a REM behaviour disorder, and more to that point, the detection of bruxism has become quite systematic, which makes it easier for us to look at RMMA and see, is that bruxism, or is that myoclonus, or is that just snoring? Is it just facial movement from somebody who's snoring 80% of the night? And I mean, you've seen a few sleep studies of late where that's just been obvious as hell.
Yeah.
But when it comes to detection of semi-voluntary subconscious activity, as I like to call it, you can ask people in your questionnaires that you give them when you're seeing them about, especially if they've got a pain, even a transient pain. Oh, I haven't had pain for years and now I've got a sore jaw and I don't know why, kind of pain. But like lip biting, pen chewing, I've written the list down here because I don't want to try to remember it, but cheek chewing, tongue chewing, even one that I've just recalled, an old lady that I used to deal with, she used to put pins in her mouth when she was sewing. Like holding them there so she could have easy access to them. And she ended up with worn teeth, but also a sore jaw.
Yeah.
And it was because of that semi-voluntary subconscious activity. I mean, yes, she was putting the pins in purposefully, but she was also chewing on them when they were in there.
Yeah.
Didn't even realize it. But the definition of bruxism a lot of the definitions actually include with or without tooth contact. And isn't that interesting? And it's because this semi-voluntary subconscious activity doesn't always have to be all about the teeth contacting one another. And that's why sometimes it can be virtually impossible to tell that a patient has bruxism just by a clinical exam. Some teeth actually don't look worn, but yet they've got a TMD. And what's that all about? You know, like they've got a TMD and not a lot of wear on their teeth. You know?
But I think if you ask when do they get the pain, these patients, the headache pain is normally in the evening, where the other type of patients tends to be definitely when they wake up. So that's something I kind of ask.
Yeah, it's a
but again, what's your thoughts on this, Chris? Lots of dentists say, oh, look, I can tell whether they're clenching or bruxing based on their wear facets. I've kind of tried to figure out what they mean by that, because it's not as though a clencher is going to have a very characteristic wear facet versus a bruxer. What are your thoughts?
Well, I mean, if I use myself as an example, I'm a clencher. Not so much these days because I wear a mask every night, but that's another story. But I have some wear on the cingulums behind my upper anteriors because I've got a deep anterior overbite. And I have a little bit of a wear facet on the molars on the sixes of the lower, the mesiobuccal cusp. Oh, no, it's actually the distobuccal cusp. There's a wear facet on either side. But what I've noticed after my longitudinal study of 55 years, it's I've broken my teeth. I don't have one filling, but I've got cracked front teeth, and I've had some restorations done in composite. And it's because of the constant pressure on my teeth from clenching over many, many years. They've finally just given up. Do you see what I mean? Like, they've just given up. And nobody's going to see that coming.
Yeah. What are your thoughts on some dentists tell me they can pick the clencher because the temporalis is more involved, and these are the guys that do the NTIs and whatever else, whereas they say the bruxer is more a figure of 8 and it's more the masseter involved. Any thoughts on that?
Yeah, I'd be challenging to say that I agree with it. And the reality of that is that, unfortunately, look, the clencher doesn't necessarily just clench. They'll do tiny little circles. A grinder doesn't necessarily grind. They're more or less just moving from a centric relation perspective back into a centric occlusion involuntarily, unknowingly, unwittingly, and in any particular position, and even up to depending on what side of the bed they're on, you know, which side they're sleeping on, and where they're partially atonic musculature is situated before they get woken up again by an arousal. So that, in my opinion, is it important as to whether they got a big masseter or a big temporalis? I mean, in the end,
I've had patients who had both.
Yeah,
firing in both.
Yeah, and look, in my opinion on bruxism in general is that you've got 3 losers in this. You've got either the teeth, the muscles, or the joint.
Right.
And depending on what kind of parafunction they've got, depending on their physiology as well, and when they're doing it, that's when you're going to find out what's losing best. You see what I mean? So I think a multidisciplinary approach is, you know, in terms of having a sleep test, having a dental exam, that sort of, you know, even as you would very well know, even having cephalometrics to know what sort of angles they're dealing with.
Exactly. And as an orthodontist who has a special interest in dental sleep medicine, I use the Ceph. I use, Epworth sleep scale. I use what I see where in the mouth. I ask the right questions, stop, bang, things like that. And, I send a lot more patients for sleep studies than I ever used to. And a lot of them come back and they say, I'm so glad you told me that, because that answers a lot of questions that no one else could answer. And some come back and they're absolutely fine, but they're not upset that they had a sleep study, particularly if it's bulk bill, the famous 2 words in medicine in Australia, isn't it? Bulk bill, Now, look, this slide, I know you've got from the Edmund Tay Mai Hyong Endowed Fund in Singapore, and this is an interesting story. I lectured for many years in Singapore, and I've met his son, David. And David, his father died of sleep apnea, basically, right?
Oh,
And
wow.
so he wanted, and David's a prosthodontist, basically. He works with that T32 big group of dentists and dental clinics in Singapore. And what he does to give back to the profession, he wants dentists to be educated and to realise that they can help people like his dad before it becomes a sad outcome like what happened to his dad,
Comorbidity, hey,
right?
yeah. I mean, like, what you then would know then is his interesting finding about the NTI. I mean, this is
exactly.
And this is where I was alluding to in the first place. Look, I know dentists who what do you say? They swear by an NTI, and look, honestly, most of the time they're going to be just fine. But I think. Do you know the story about what David found?
Yeah, yeah. He told me when I met him that he sent all his patients for overnight sleep study, and when he did a full investigation, he discovered every single one of them presented with this, divot exhibited by REM sleep bruxism. So as a result, let me see. I'll see. I wrote down some notes here. So I knew you were going to ask us this. 25% of his patients were presenting with a large divot in the surface of the deprogrammer, right, which is what you're seeing in the diagram on the bottom right, right? Now, when they did a PSG exam, all of that 25% with a divot were suffering from REM-related sleep bruxism. So in his words, the trigeminal jaw opening reflex, like all other protective reflexes, is attenuated during REM sleep. Therefore, the NTI would be ineffective in reducing elevated muscle activity if the patient's bruxism occurs during the REM phase of sleep. So in other words, pick your battles and pick the battle you know you're going to win. And I think that's excellent coming from someone who's done so many sleep studies and so many patients. Do you want to add more to that? Because that's a yeah. Go on. Yeah.
Who's the guy from America who interviews lots of dentists? He's Dental Town or something like. Is it?
Oh, yeah, Howard Farran.
Howard Farran, yeah.
Yeah.
Is he got something to do with Dental Town, that online?
Oh, he owns it.
I don't know. Oh, okay. Because there was a massive discussion on NTIs years ago about how some people were, because as I said, I know a few dentists who swear by anterior deprogrammers of all different sorts. NTI is like saying McDonald's, isn't it? Like NTI.
See, the debate in MTI from my circle of, dealing with people, prosthodontists never use them because they always say, look, it's going to cause an open bite. And I say, well, it probably would if someone wears it 24 hours a day because you can see the molars will extrude, right?
Yeah,
because the incisors are intruding. Yeah. Same as if you wear a gulp split 24 hours a day. But the safe thing and what's straight out of Dental Council regulations nowadays is you need to have full coverage splint. And that's, again, where these people may get themselves in a bit of poo if and when a patient complains that, look, I had perfect bite until I started, and yes, maybe my pain went away, but now I've got an open bite, and you're going to pay for the ortho to fix it. That's another side of it.
Well, I would say anybody who wants to use an NTI and they've used them time and time again and never had a problem, if they're at all concerned about ever having a problem, well, having a sleep study and determining that a patient doesn't have that broken atonia, actually functioning in that other state, which is REM, is going to be a dead set winner for them in terms of they can safely prescribe the NTI. And they'll have the records to prove why they did it. That's what I wanted to say about that. I think that for me, we're pretty boring, aren't we? We talk about this stuff all the time. I would say.
And the thing is, most of our audience just want a recipe book, cookbook. Is it A or B? And if it's A, what do I make? If it's B, what do I make? That's what I.
So I say, if you're gonna make an anterior deprogrammer, do a sleep study first, because then you've got a reason why you did it. Otherwise, you could be in trouble because you're not going to know what you don't know. Yeah, that's.
I mean, this is a good summary slide. And after this, I'd like you, if possible, just to look at a sleep study because I know you do that very well. So 80%. Now, I'm not even going to try and I'll just say RMMA. So, because Chris has already very eloquently defined that. 80% of all
masticatory muscle
activity is related to autonomic arousal, right? With or without tooth clenching. So, if they're grinding their teeth, you can see it easily enough, right? 50% correct.
Yeah.
If you're only going to have to put a splint in the mouth anyway, what's the point of knowing more? Because 30% of the time you'll be correct, but 70% of the time you're wrong. That's pretty bad stats. Fixing the bite will assist in stopping bruxism. Now, as an orthodontist, do you know how many times I get a referral from a dentist and they say, look, go and see Mahony. You got an overbite. If he fixes your overbite, you stop bruxing. And I've got to say to them, no. The last thing I want is to promise something like that. The statistics 100% say that bruxism is not related to the type of malocclusion. And if that was the case, everyone who was dental div 2 would be a bruxer, right? But, definitely not the case. So I think I definitely agree with the last statement, right? So determining that a sleep disorder is concomitant with the evidence that you see in the dental clinic will determine what kind of therapy you're going to use. And that's what we're all about in this lecture.
Yeah.
Do the preclinical evaluation, your Epworth scales, et cetera, et cetera. Talk to the patient about why it could be A, B, or C and how you need a sleep study to confirm that. And then from the sleep study, from what you see in the mouth and from your history, prescribe the right appliance. Now, here's a sleep study. Chris, I'll let you talk on that one.
Well, this is a part of a sleep study. You can see the light grey bit in the bottom that just says N3, N1, N2. They're different stages of sleep. So N3 sleep is deep sleep, and that would have been proceeding off to the left of that snippet. And then off to the right, we've got some light sleep. Then we try to get into a deeper middle sleep, and then goes back up into a light sleep. And curiously, there's a bruxism event. But look, right at the top of all of that, you've got number one, which, as you move along, you see right from the left to right, you see some hypopneas, then you see an orange red type of thing. That's an arousal, just marking that because the brain signal is actually missing on this snippet. But then you've got a blue line in line there, and then beneath that there's a brown series of lines, and you can see some disruption in the line. That is phasic bruxism happening because it's a high pointed short duration spike. And then you've got a series of 3 versions of that, and a couple of them have twins, so that's like more phasic bruxism in amongst hypopnea. But what's really interesting is you look at that relative desaturation there from in the middle of the screen, and it says 95, that's 95% blood oxygen saturation. And then it drops down, even though it's not an absolute, it's a relative because it's not more than 3%, it goes down to 93%. Now, while the body's feeling that, you've got the onset of arousal, increase in muscle tone, and bruxism happening. Then you've got a restriction in airway again, and then the cycle repeats all over again. Now, each one of those lines running across that screen in a vertical sense, they're 30-second epochs. So within a minute, within 2 minutes, they've had, essentially 1, 2, 3, 4, 5, 6 events of bruxism, if I wanted to be really picky. But in a phasic sense of RMMA, sorry, I'll correct myself, of rhythmic masculine muscle activity. But in terms of bruxism, they've had 2 events of bruxism because you've got to group those phasic events together. But it always starts with an airway event, secondary bruxism. This is non-REM, so it's not dreaming sleep. An airway event, an arousal, which brings on a return to muscle tone, and then a resetting of the airway in this case, which gives you that bruxism event. So have I missed anything, mate?
No, good. And then how about looking at the REM?
Well, this is our 12.8%. So specifically with this, I wonder if I can use a pointer. Can you see anything? No?
You know what? Because I've got to make you the thing. What do you mean to point to?
let's not
I,
do that then.
I can use a pointer, but I
Oh,
don't
there
know
you
whether I
go.
can.
No, that's
Yeah,
good.
but,
That's good. So you see off to the first series of events there, which is just off the left-hand side.
yeah,
You can see that's that's called a RERA. That thing that you just saw, you just had the cursor on, that sort of browny purpley thing. That's a RERA, which is a respiratory effort related arousal.
mm-hmm.
Indicates that there's an arousal on the way. That arousal is covered over on this particular slide by the significant dot of blue, which is a phasic bruxism event again. So you see the pink line, which is the breathing line. You see that? That's the pink line there, yep. And that's the RERA on the pink line, which was just to the left of where you were going. And there's another one, yep. So that one.
Longer one, yep.
Yep. Now you see those 2 to 3 big breaths happening. Any one of those you want to see, actually. Off to the left around the 55, 51, 60, and then you go straight ahead up on top. And what it's showing is you've got an increase in pulse rate. You've got a stable oxygen level, okay? So that's not what's causing this. It's not oxygen desaturation. Does that make sense? Like it's a limitation in airway, sure. Airway size, which is what a respiratory effort related arousal is, because you're getting an increase in effort as you're breathing. Where these RERAs are happening, I like this slide because in both cases they're slightly different. One case you've got less snoring, where it hasn't actually marked up as snoring because it's not high enough in volume or intensity. So you've got a RERA, then you've got some snoring because the airways close down even that much more. Then they get 3 large breaths against effort, which then causes the bruxism, which is the phasic bruxism, which is breaking the atonia that they would otherwise and should otherwise have in REM sleep. Then they travel along for what is 1, 2, 2.5 minutes, and then another increase in pulsatile rate. Their heart is beating faster. They have the 3 breaths again. There's the phasic interlude, and you've got your arousal just prior to that. It's so close that they're actually almost what looks like overlapping one another. And then again, excuse me, you see a RERA event that's happening with snoring. So they've got their mouth open, their airways restricted because of the downward action of the mandible, and then their body actually responds again in a sympathetic nervous system kind of way, which is what that increase in pulse rate is, and then those increase in breath, and then you've got the break in atonia again. That is real bruxism in terms of what the ISCD terms bruxism. So that's why I like that screen, because look, I'm looking for it on every sleep test. And when I see it, I make a point of it to tell you this is sleep bruxism. There'll often be a couple of those sort of shots.
And that's really good for dentists to realize that the reports they may be getting back that are classical sleep studies really aren't reporting on what dentists look for. It's a bit like if you send your patient for a medical to a medical radiologist for an OPG, what does your report say? Teeth are present normally, or something, really amazing thing, whereas if a maxillofacial radiologist reads your report, he's going to say, right, Eagle syndrome, possible caries on the 4-6, blah, blah, blah. It's a dental medical thing. So if you get someone from a dental background who's also a sleep scientist like yourself reading this from a dentist's mind, you're picking up the stuff that I find that very, very useful. Do you want me to just go forward now and you can continue?
This little slide here, I like this slide because it explains the without tooth contact part. Because this is a particular patient who was sent because they have temporomandibular disorder, and they've got tooth grinding or gnashing that's absent throughout the night. So they're not actually tooth grinding or gnashing. But look at those, look at that frequency. Look at this, the consistency of the frequency. Now, in hindsight, I've inaccurately marked that. I must have got a bit lazy, because there's actually 2 series there of FFM, which is faciomandibular myoclonus. You can see how those constant high frequency, like high enough to be over and above the level of what you'd want to measure it at to be able to measure it properly. but there's consistency in between the bursts is very consistent, like a marching band, and then it drops off and then it happens again. So in the first place, you've got myoclonus happening there, which is a vibratory, almost a, I mean, when I say trismus, people think trismus lockjaw, but what I'm saying is it's just this juddery vibration in the muscles that's causing this facial tic thing that happens. And then you've got your airway event, and then, you know, the third thing is you're getting slow eye movement, which is different to REM. You know, REM is rapid eye movement, and slow eye movement is akin to like almost an alpha wave thing. So that's an arousal based eye movement. It doesn't detect REM though. And this sort of thing is happening all the time, and it ends up in this patient with, you see that thing says blue, I think you can just read, it says Brux phasic on it, and that's around the, I've written Orbicularis there because that, that's it. And just above there, there's got number 2. That's the chin showing that the mouth is opening and then the teeth are chattering. Everything's all wrong. Everything's out of sync. You know what I mean? Everything's out of sync. Yeah. And this person is clenching, but what are they clenching on? My guess is they're clenching on their front teeth and they're crushing their disc at the same time, which is why they got the TMD. I mean, you see that pulsatile increase there as you get to the actual bruxism. Through the whole thing, there's no great pulsatile increase. And then just where you had your pointer before, if you go straight down to the black line there, it goes from 58 to 71. Like that's an increase in pulse rate over about 20 seconds. Like, what the? That's a sympathetic response from hell. So that's an intense response, and this is a TMD patient. So we've just confirmed why they've got TMD, because even though they don't have a lot of bruxism in the test, when they do, they make it really a good one. They do it really well. They're experts at it. You know? So like that's autonomic arousal as well. That's muscle activity activation. So what have you got to add about autonomic arousals, mate?
Well, papers that I've read, and I've got a reference down the bottom there, the pathophysiology of that rhythmic muscular activity is associated with autonomic sympathetic cardiac activity and sleep arousals, right? So when people ask, you know, those arousals are normally a response to either external or internal factors. And sometimes the purpose of those, or the active periods, are where someone's adjusting their body temperature, body position, reset their temperature. They become fully awake if there is perceived to be a threat. So I think it's important, and I think this is a classic paper, and this is the one that I normally open my lectures with when I'm talking to a general dental audience who have no idea about sleep, right? I say, if you quote this paper, and there's your mate, Gilles Levine, very respected peer-reviewed journal, International Journal of Prosthodontics in 2004, that open study suggested that the use of an occlusal splint is associated with the risk of aggravating the respiratory disturbances, right? Yeah. So therefore, I think if you just give every man and his dog a flat plane splint and don't question about snoring, sleep, etc., you could really be opening yourself up for medical legal problems. That's, you know, bottom line. Anything you want to add to that?
Well, I mean, there's like I had a look at the study because you told me you were going to build it in there, but like 50% of these patients, they had an increase in their respiratory disturbance index. So that's airway events coming on because they're wearing a splint. And what's that all about? That's about a downward arc rotation of the mandible into the throat in a person who's potentially what you call a class 4. You know that? That's retro positioned. They look like a class 1, but everything's just too far back against the back of the throat. And I mean, as soon as you start to do something like that without advancement in a patient like that, well, it's all over. So determining that patient could have an airway problem before you give them a splint means that you might actually make them a mandibular advancement splint instead of a normal flat plane splint. And we, you know, I'm getting dentists sending me patients for mandibular advancement splints, and I'm not promoting myself. I'm just saying that people are making mandibular advancement splints for TMD patients. They're not doing it just for sleep patients, and they're doing it for TMD patients who what they would consider would be a primary TMD patient who have a secondary sleep apnea score, which might be quite insignificant, but they know that if they put a mandibular, a regular, what they call MOS, a maxillary occlusal splint, in their mouth, they're going to potentially make that score of airway events increase. So they don't want to do that.
And the other thing is, you know, when I went to dental school, we had two textbooks. Occlusion was Ashford and Ram, I think, or Ram and Ashford. And that was all those bloody equilibration theories, right? So the next slide is going to blow that out of the water. And of course, the other book was Ivan Kleinberg's book that was compulsory purchase.
I've got that one.
He'd just come back from Michigan, University of Michigan, because everyone got a Michigan splint, you know, with the little canine guidance. And, you know, I've used some of those incorrectly and caused TMD because the patients hit the canine guidance and pushed the jaw back. But look at this slide, right? For those people who, you know, into, what do they call, Chris? The gnathologist? Is that it?
Gnathologist?
Yeah. My definition of gnathology is a study of the way articulators chew. How does that sound? You know? Yeah. In the have I offended enough people on this little broadcast? No. I'm being facetious.
You can see the numbers, can't you? They're switching off. They're gone.
Yeah. So look, but this is a really good one. This is by old Anders Johansson, you know, famous as hell in the field, right? This is in Journal of Prosthodontic Research. Look at this. When prosthetic interventions indicate in a patient with bruxism, efforts should be made to reduce the efforts of likely heavy occlusal loading on all the components that contribute to the structural integrity, right? But here's the big one. There's no evidence that prosthetic therapy or any other available treatment, can eliminate bruxism. So equally, there's no evidence that bruxism can be caused by prosthetic therapy. So there you go.
Yeah, so he's saying try to limit it, but because no matter what you do, if they're bruxing, they're going to break it. So, you know, in the end, like I've done some mini residencies with some prosthodontists in Sydney, and they were very big on and careful too, I must say, about making sure that you can get the load just so on particular types of prosthetic appliances. But whilst I was sitting there, and I had a silent chat later, that's why I'm not mentioning names. And I just said after the fact, look, wouldn't it be wise to put some sort of splint in there to share the load more effectively in a patient like this, or even just think about doing something a bit more than that? And they said, well, absolutely, but we've got to think about daytime as well as nighttime. And I think that's a big statement, isn't it? We've got to think about daytime as well as nighttime. So if we're thinking about nighttime, let's judge what people do differently in their nighttime.
Yeah, and then that brings us on to this study. Again, Gilles Levine is involved in this. This is where they're comparing your MOS, maxillary occlusal splint, with your MRA, mandibular repositioning appliance, right? And what's the short-term use of this is a temporary custom fit MAD, which is mandibular advancement device, is associated with a remarkable reduction in the sleep bruxism, okay? To a smaller extent, the single arch occlusal splint, which I was referring to earlier, whether you call it a Michigan splint or etc., also reduces sleep bruxism. However, the exact mechanism supporting this reduction remains to be explained.
Hypothesis 2006,
hypotheses are orientated toward the following: dimension and configuration of the appliance, presence of pain, reduced freedom of movement, or change in the upper airway patency. Chris, you want to add some more comments on that?
I think it's like I want to try and like spell it out to people that I think the big words in that statement in the second point there is changes in the upper airway patency. What's causing the change? Is it the balance of the dilator muscles of the throat because of an a mispositioned lower jaw now. It's incapable of having those dilated muscles extend properly. Like, so if you're going to increase a vertical, if you're going to retrude a lower jaw into a less opportunistic position, okay, so let's say for a minute, let's somebody puts a mandibular occlusal splint on a patient's upper jaw to stop them grinding their teeth at night. Sure, the lower jaw is free floating. It's able to move around wherever it likes, and in line with what I think, you know, and how I feel, and not just myself, but a lot of people, you've got your freeway space in your mouth, you've got your centric relation happening there at night. Somebody's breathing through their nose, hopefully, most likely their mouth.
Yeah.
They will have a restriction of some sort. And as we know, if people are going to do your OSA courses, they're going to find out the details of what that some sort is. But we're not here for that tonight. In the end, we're talking about some sort of interruption to their airway causes them to brux their teeth. Well, if they're in a maxillary occlusal splint with canine guidance set at the position of the canines on the upper jaw that's at the base of the skull retruded, what's going to happen? They're going to hit that anterior guidance, well, and do what? Just sort of go back into some sort of pathological position, which is just replicated on the top of the splint and spelled out and drawn up with Gothic arch tracings up and down the splint in about a month. You know, so a patient comes back to the dentist, are you using the splint? Well, they look at the splint, they see Gothic arch tracings all over it. What do those Gothic arch tracings tell them? You see what I mean? I think that's more of an indication of where those muscles are functioning to during the night, rather than where the splint is coming from. Because what I know from my prosthetics business and the action of making prosthetics is that if you're using a Gothic arch tracing, you're looking for a retruded position. So if somebody is going to make a Gothic arch tracing for you involuntarily every night in 28 positions up and down the splint, or 14.
Yeah.
Okay, let's be funny.
You know what this slide is, what makes me do? I'm going to, before we end the lecture, I'm going to get out the appliance you made for me, the one that I've used for years, but I never cleaned. That would be a bit embarrassing.
Oh, really?
Yeah.
The other
and
one.
Then the brand new one.
Oh,
and the brand new one. But the wings of your brand new one are much easier to click in and out. And I might kind of explain to people, if you're making someone an MAS, muscles adapt after a while. So you've got to keep fooling the jaw into changing position. And I find that, and in which case I'll go and, being in COVID, I actually wash my hands before I go and get my appliances.
Excellent.
Let me put this slide up, because this also shows how dentists can make their even flat plane occlusal splints more effective. You talk about that, I'll go and get my appliances.
Yeah. Hang on. So that the previous slide did show a pivotal contact, and I think that's critical in stopping patients from parafunctioning on a stabilization kind of point. So the further back the point is of contact on the splints in between the upper and lower arches, in a person who has any type of REM behaviored bruxing, the more likely they are to continue to clench on that at night. And if they do that, the fulcrum is different. It's not as comfortable for the patient. You'll get a lot more complaints. What I've found over the years is by changing the pivotal contact to be mid splint, just like we do in dentures, you're going to get a better spread of load on the jaws. So the research that's on that previous slide will sort of hold up to that. In terms of the slide that we've got in front of us at the moment, the study there, which I found was fantastic, was that they threw out the idea that there's no effect, there's no difference in the effect of sleep bruxism between continuous and intermittent use of stabilization splints. So this is a different term. This is not a mandibular advancement splint, but it is a stabilization splint. So what they did was they said, let's change the way people function with this thing by tricking the body. We'll work with them for a week and then we'll leave it out. Then we'll put it back in, we'll leave it out. They found that the efficacy of the splint remained much longer than the adaptation of a splint to somebody who's using it 24/7. And that's the key, is the adaptation of a body to a situation, which is how people get into a bruxism situation in the first place. Put an orthotic in there and leave it static, and it's going to adapt. The patient's going to adapt to that orthotic. So did you hear that, mate? Or
Yeah. No. I think, in fact, I'm gonna embarrass myself. When you work as hard as I do, and you come home, the last thing you remember to do is put your appliance in, so the missus doesn't say, "Oh my God, you snored last night," you know. And it's a bit of a sliding scale. The more you drink, the less you're going to remember to put this in, and the more you need it. Would you agree?
Yeah.
But look at this one. I'm going to embarrass myself. This is Chris's first one he made me. This is like it's about 4 years old, I think. I don't know.
Yeah, at least, yeah.
Look how dirty that is. I'm very proud of that, Chris. That's you can tell it's been used. You can tell it's been used. But see that those are those little fins. I don't know. Can you see those fins?
Yeah.
Those fins. See, this background makes it, doesn't it? Those little plastic fins are nothing compared to this one. I love this. All right, you'll be pleased to here you go. I don't know will I get in trouble for this. You'll be pleased to know the dirty one I keep in my Somnomed box. There you go.
Excellent. Yeah. That's...
and the new one I keep in that nice little box you gave me, which comes with your little cleaning device. That's I actually clean this with other. So look at this. This is so comfortable, and I do this to all my patients. So look, I wear one of these. On top. All right. Now, in theory, that could just be your occlusal splint, but then at the lower, and that position really works for me because it stops me snoring, and I know that from
not snoring.
Not snoring, yeah. And I feel so much better. You know, when I did the sleep, I'll take this out.
Yeah, I think so. You're starting to sound like Alan Seal.
Now look at this. Look at those little babies. They're resin printed as well, aren't they? That's much better wing that you put on that. I like that.
Yeah, they're the same material, exactly the same.
But what works even better, right, when I remember to use it, is your lip shield. So when I do is I put this in, I put the lip seal in, and I go, and I can feel my tongue hit my palate, and correct me if I'm wrong, but I get much better nasal breathing out of that. So I think lip seal is what everyone is forgetting in any bloody appliance. I don't care what brand you're with, etc., etc. But when you're using these appliances, and I'm a classic, I have sleep apnea, and I brux. I brux because I'm a type A personality, and even if I didn't have sleep apnea, I brux. So I'm one of those, write the book on it. But what works for me is 100% my mandibular repositioning appliance with my lip seal device, if you want to call it that. And it sounds even more appealing, and that's why I think this is better than the best form of contraception, actually. You put that in, you put your lip seal device in, and I shove those nasal cones up my nose because of my deviated septum, right? And there I go. I get the best night's sleep. Now, how many nights a week do I put the nasal cones in, put this in, and the oral shield, right? Maybe 4 out of 7. But my God, I really feel different. But I've done my own diagnosis from my CBCT, which you've seen. I need the nasal cones, right? My nasal valve collapse, right? I used to use those breathe right strips before you put me onto the nasal cone. So that works for me, but on its own, not as effective. The mandibular appliance works for me on its own, not as effective. The lip seal works for me. But if I add all three together, I 100% feel better. And you're going to show a slide now, I think, of what I went through, and I go through this on a yearly basis because it really. Do you want to explain the home sleep studies?
Well, this is actually a relative of Gillian's who works with me, and he's graciously allowed me to show how gorgeous he looks when he's got this thing stuck to his face. But you can see that if you look at the picture on the right, you can see there's the EEG leads, which are up on the top of the head, and then we've got the the black lead in the middle of the forehead, that's a reference lead. And then the leads around the eyes is what's going to check your REM sleep for rapid eye movement. But really importantly for us is those yellow and green leads on the above the beard in this case. And there's a lot of beards around these days.
Oops.
There he is.
Yeah.
He shaved. And those are the leads.
I was going to say, and then when he woke up, he looked totally different like that.
It takes at least 40 years off, doesn't it?
So does everyone work for you have to kind of look like you? Do they have to grow the Jesus beard? I just kind of figured that out.
Well, Gillian's not as hairy as me. She
Right.
doesn't have a beard. I hope she's not watching this. But yeah, no, this I don't know if you would agree or not, but that what we call the air headset.
Yeah, this one, that thing there. When I did my original studies with you, it was a lot of hit and miss. That little, what do you call it? Air headset.
Just call it air headset, yeah.
That really makes it more comfortable, but also makes it those leads know exactly where they need to fit. So it makes it pretty easy.
Yeah. And we've done hundreds and hundreds of tests now, and the headset's a new addition. People get a bit freaked out when they see all these leads everywhere, but ultimately, they don't call it the little death for nothing, mate. When you sleep, you don't know. You're just not there. So this doesn't really bother most people. And if anything, it's a testament to proving insomnia. If they can't sleep with that on, then...
We're getting some really good comments here as I'm watching the little comments as they come in and out. And Steve Tracy, I know you do a lot of work for. He's a legend. He said, I love the AER shield. Right, absolutely. That's a term I should have used. I call it the lip seal, but right, is that right? AER shield.
Yeah, it's a tongue position shield, and it's for cognitive behavioural therapy at night when you're asleep. And it's, in my opinion, as far as I know, it's the first kind of shield of its sort that actually has borrowed. Look, I haven't made this thing up. There's a lot of research behind it for different uses of anything from the first type of appliance was a tongue repositioning device. So you put that, it's just the tongue repositioning shield, the tongue positioning shield, whatever you want to call it. It helps people to know where their tongue is at night, and that's what's been missing in oral appliances for years. Sound like I'm blowing my own
I'll tell you what, you keep talking. I'm going to even go and get my AER shield.
AER shield.
That's the last slide for our joint presentation, and we wanted to keep it about an hour, so we're doing pretty good.
Yeah, we've done well.
Let me go and get that shield. You say something, and then we'll get some questions.
Well, next week we're going to be talking about oral appliances specifically. I've called it a deep dive into oral appliances, and there will be more discussion on that kind of addition to oral appliances and my functional therapy mix in with mandibular advancement. So I think it's important to get into more detail when I've got more time next week. People do use all sorts of things to try and keep their airway clear at night, and I think it's more of I always think it will be more of a combination of things. So if you're going to do a mandibular advancement splint for somebody and it's not totally working, don't give up hope, because ultimately it's just part of the armamentum that you could be using when you're dealing with sleep patients, and you've got an airway that's got at least two openings, your nose and your mouth, and you've got to try and keep all of that working in the right sequence and working in a patent way. So it's more than an oral appliance, it's more than a pair of nose cones, it's more than a CPAP. It's a combination of CPAP and oral appliance. I think that's important to remember. And the more you get into this, the more you need to seek out companies that are going to work with you for oral appliances and CPAP, so that you can put it all together and do the best for your patient. So the problem with Derek buying a big house is he's got to walk half a mile to get to his bathroom, I think, unless he goes through that portal, which is created in the back of his slide there. It looks like he could walk straight through that and be in another room. That's my segueing exhausted, just sitting there. So let's see. This is fascinating. I don't have any contact with the questions, I'm sorry. So if you're asking one, I won't be able to answer you just yet. But when Derek comes back through his portal, I guess we'll be able to see some more questions and have some more answers. Yeah, that shield, I'm glad Steve likes it. It's a big compliment to me if Steve Tracy likes something. I've known Steve for a very long time, and if he's convinced about something, then I know that I'm onto something good. Here we are.
You know what? I'm embarrassed to say this. I got a new cleaner, and she's so good. she puts everything away, including what's next to my bedside table. So I can show you one that hasn't been fitted.
I actually have one. I might go and get mine.
Yeah,
right,
because this is the missing link, no matter what appliance you're using, right? Because I tell you, just try this for yourself. I want everyone. These are really easy to use. You just mold them in some hot water, put them in your mouth, and go. So in other words, put your tongue up on the spot, put your lips together, and suck in really hard. And as you do that, you'll feel your tongue being sucked into that position, which is really important to get the most out of your MAS, right? So I think Chris has done a great job with this little AER shield. That's one that hasn't been formed yet. And I will find mine because I want to sleep with it for sure. There you go, Chris.
Can you see this?
Yeah.
And then I put my shield in. I've got this one before I put the arrows on them, so now I've got an arrow.
Yeah. Yep. Yeah.
What I'm showing you is when I sleep at night, my tongue just automatically, because I've been wearing these devices for a long time, my tongue automatically now comes forward and sits in between the upper and lower pieces. So I actually put a bump on the front of my shield. Can you see that? Bump?
Yep. Yep.
And now when I put that in, my tongue can fit there. And it's like a tongue stabilizing device as well as a tongue posturing device, because my upper jaw is actually quite far back on the base of my skull. So my tongue's not meant to fit in the top of my mouth, if you know what I mean. That makes sense?
Yep, perfect. And in fact, I haven't got time to add this to the PowerPoint, but if you're all on my Facebook, go down a couple of posts the other night and you see me. You can use my slides if you want with all the device in. Just trying to show where that. All right.
Oh, yeah, with the red marks on it, where you.
Correct.
Yeah.
I'm just trying to think where she's posted the last one we did, which was
last Thursday. What, the lecture or?
Yeah. So I'm just going to ask if they like this one. They missed the first one. So this is part 2 of a 3-part series. You've talked about the one next week. That'll be really a lot more on the MAS.
Yeah.
So it's the same time next week, Thursday, 7 p.m. Sometimes both Chris and I get stuck with patients, and so we're a little bit late. But where is it? Look at my post for last Thursday, and it'll still be up there to get number 1. I believe. I'm just going to make sure I'm not lying. And number 2 is this one here. We're going to leave on this Facebook page for the next 3-4 days, and then it's going to go to eodoteachable.com. So, Chris, I've got to double check. But if you like what we've got to say, please share this with your friends. And if you have questions, because it's running a bit late at night now, we're a bit over time. But if you have questions, feel free to put them in the comments section on any of those Facebooks, and I or Chris will reply to them. Just trying to find where that is. Here we go. Good summary.
My question to you, Derek, is if I reply on one of your Facebooks, it doesn't go to all of them, does it? So I've got to sort of look at.
Yeah, that's right. Yeah. On all four. I do try and look at all four. Here we go. Yeah, that's pretty good. You got 4,000 views for number one. That's not bad in 1 week.
Yeah, that's pretty good.
Yeah, so 9th of July, there I found it. So if you go to any of my Facebook feeds, go to 9th of July, and that's number one. It's still up there, right? That was the one, an easy way to tell if your child or adolescent patients have some sort of breathing problems, perfect for dentists, right? Tonight's one is more obviously on bruxism, which I think is also dentally related, and the next one is going to be on mandibular repositioning. So, Chris, I think we might need to call that a night. Only because my little puppy here is looking at me with the saddest eyes because he's starving, and I'm all right. Well, thanks for that. That was good. And
well, I've got to drink more of my coffee.
Okay, cool, cool.
Yeah, coffee.
Right. And thanks again for all you do for the profession. Honestly, like when it comes to the field of dental sleep medicine, you just made it super easy for dentists. They can get their patients bulk bill for a sleep study. You can then look at the study with them and tell them what appliance to use. It's really great, and you're helping so many people. I know, I mean, you know, since we started working together, the number of case studies that I've done successfully has jumped because, you know, we're not just fitting everyone with the same appliance at 70% protrusion. That's what I used to do for years, and I thought I was a guru, you know.
Well, you know, look back at you, man, because I've got to say, without people having faith in me to be able to do what I do, I wouldn't be doing much at all. So I appreciate the dentists, their trust in me, and it's, as you know, because you've seen my journey over these last few years. I've gone from dental technician doing orthodontic appliances to a sleep scientist doing all sorts of stuff. So,
you know, people may not know this. I'll end tonight's lecture on this. Chris and I went to school together, not just you know, like school, like as in Patrician Brothers.
Yeah.
where Chris used to not attend classes and go down the creek and smoke dope in between lunchtime. Can I say that?
It wasn't dope. It wasn't. It was smoking. It was terrible. I don't do this at home, kids. That's what I say. Otherwise you'll end up like me.
All right. So guys, thanks for tuning in. We'll see you next Thursday. Look forward to any questions between now and then. Other than that, I am going to end the meeting for